by all your ongoing activities. It's great for me to be here today. I had some time to spend with some of you and your colleagues at Grady this afternoon, and just really good to hear the team-based initiatives that you're engaged in, and really that's the essence of critical care practice as well. So I'm thrilled to be able to talk with you this evening just in terms of some strategies for conducting clinical research. That really has been an interest area of mine, and certainly as critical care clinicians, you know the importance of really replicating research, conducting pilot work, looking at quality improvement initiatives, and it's certainly something that the Society of Critical Care Medicine has supported as well throughout the years, not only looking at focused research initiatives, but also quality improvement collaboratives. And we now also have launched our research network, Discovery, this past year. Dr. Greg Martin is involved with that, and we're excited to be able to have for the first time a critical care research network as well. So I have no disclosures with respect to the topic. And in terms of specific objectives for your continuing education, I'm going to highlight just some of the importance of clinical research in critical care, and I'm sure you can relate to a lot of that, to highlight some areas of how we can promote clinical research in practice. Part of my role at Rush University Medical Center, I'm director of our Center for Clinical Research and Scholarship. And so we really try and promote multi-professional led initiatives to improve care. We have a variety of clinicians who take leads on our clinical projects, from physicians to pharmacists to nurses. It really has helped provide our care to our patients at the bedside too. And then I'll talk about some strategies for looking at priority areas of critical care in clinical practice. And when I speak about clinical research, I'm not talking about randomized controlled trials and those types of trials, but really clinical research that we put into play as clinicians. Many times we have best intentions by changing a practice, but we don't pause to collect baseline data and then look to see, does that practice change, improve patient care? And so that's what we've been advocating for when we talk about clinical research. You know, we can also apply for research grants and do full-fledged research in that sense, in terms of having control groups and randomization and intervention type research. But we need to take a look at how we can integrate clinical research in our daily practice in critical care to really improve care. So we all know that research is important to clinical practice. It really serves as the basis for what we do, and particularly for critical care. There's so much that is coming out on a regular basis in terms of new therapeutics, new medications, new ways to treat patients with critical illness. So keeping up to date with that can sometimes be challenging, and applying that into clinical practice, we know, can also be challenging. I know you've all heard the statistics that on average it would take anywhere from 12 to 15 years before research was actually put into clinical practice. We have really sped up that process, and we're seeing that we're applying research that we're reading in our journals into clinical practice. But we also know the reality is it's difficult to devote time in the clinical setting because patient care takes priority and the demands of patient care take precedence. So really it can be challenging at the bedside. There's also a research reality that despite knowing the benefits of research, there's barriers to enticing our clinicians to join us in clinical projects. Some people really don't have time, they say, to read research or to keep up with research. They can't interpret the results. I think some of the clinical journals have gotten a lot better at having research that's interpretable. It almost at times seemed that you were trying to read a foreign language when you were trying to interpret results in some of the clinical journals, but many of them have tried to really make research understandable in their journals as well. And this is helpful to clinicians. This is a cartoon that's research made simple. Sometimes when you say the word research, people's eyes sort of glaze over. I've had a strategy at our facility that instead of coming to a clinical floor or unit to say, you know, we have an opportunity for clinical research, I'll say we have an opportunity for a clinical project. Sometimes if you pose it in that attempt, that it's not so intimidating, especially for frontline staff, to say, yes, we're actually going to do a research project. And I'll share with you an actual example. At our institution, in our post-anesthesia area that interfaces with our critical care units, they had an opportunity to pilot test a new warming blanket. And so they were just going to simply trial the blankets, and we said, well, why don't we collect some baseline data on how you normally rewarm patients now. And their practice was really just using warmed bath blankets and applying that until temperature normalized. But they actually were able to quantify the number of bath blankets they were using in the warmer to rewarm patients and the time that it actually took. And so when they started the clinical project with the automatic warmer, they were actually randomizing it. So if I had gone into the unit and said to them, you're going to do a randomized controlled trial to trial this new blanket, they probably would have done a pushback. But in terms of phrasing it, we have this opportunity to trial a new product. We're going to randomize patients to control usual care and look to see the impact of it. And it turned out to be a really good opportunity for them. It was their first clinical research project. They found out that the use of the warming blankets, on average, was able to rewarm patients 5 minutes sooner than usual, and they did not have the cost associated with having to send those bath blankets to the laundry for cleaning and such. So we ended up utilizing that product house-wide, but it's just an example that I like to share to showcase that it takes time to do this, but once clinicians are on board with it, it really makes sense to do this in any clinical change project as well. So showing clinicians that we can apply research into clinical practice and that it can be done without doing official, randomized controlled trials as well. And showcasing that administrative support is key. Really you need to have administrative support to know that you need time to have someone to collect baseline data, to get data off the electronic medical record, to have someone from your systems information support, and to change those negative attitudes about perceptions of research. So this is a cute little video that I came across. I just wanted to play. It talks about p-values, and there's 2 colleagues talking. One is a statistician and one is the researcher talking about p-values, but it just highlights sometimes we get stuck in the statistics of all of this as well.
Do you have statistical results of the study completed?
Yes. Despite problems with the modeling due to multiple assumption violations and having to uninstall and reinstall an enterprise guide 5 times, we finally completed the analysis. The good news is that the p-value for the primary comparison is 0.004.
Great. So the likelihood that my findings are due to chance is 0.004.
Not really. That would be an incorrect interpretation.
Oh. Okay, good. I see. Well, you must mean that there is a 99.996% chance that there is a real difference between the study groups. Or, equivalently, there is a 0.4% chance that the null hypothesis is true, right?
No, that would also be an incorrect interpretation.
Are you serious?
Unfortunately, I'm very serious.
Well, in the recent Jones et al. Study, they recorded a p-value of only 0.03 for the same comparison. So at least I have found stronger evidence of the effect. Correct?
Not exactly. The study was much larger, so they probably had more evidence of an effect than in your study, even though your p-value was smaller. I really can't be sure without looking at your results.
But wait a minute. Their p-value is larger.
Yes, I know, but p-values are weird like that. You can't compare their magnitude unless the sample sizes are equal.
What good is that? It's rare for 2 studies that have the same sample size. So, can you explain to me what a p-value of 0.004 actually means?
Yes. If one assumes that the distribution of values is identical in the 2 populations under study, usually referred to as the null hypothesis, then the p-value addresses the following question. What is the probability that the difference between randomly selected samples will be as large or larger than actually observed?
You're serious?
Yes, the p-value is the answer to that question, so a p-value of 0.004 can be interpreted as follows. If the null hypothesis of no difference between the treatment group and the usual care group is true, then less than 0.4% of all experiments of the size in your study would result in a difference between the groups as large or larger than was observed.
Yeah. Right. Well, the important thing is that the p-value is less than 0.05 and therefore is statistically significant. Shocking. That means publication.
Well, You see, the thing is that statistical significance and practical or clinical significance are not the same thing. Just because a result is statistically significant doesn't mean that it has any clinical importance.
I haven't had enough. Please go away now.
I enjoy that, but it's just showcases, and that's why a lot of our clinicians don't want to really be involved with research, because this is the perception they have of research. They can't understand it, they're not familiar with statistics, they just don't have the time for it. But I think engaging people and looking at how are we doing things in clinical practice, what's the before, what's the after, and how can we promote change really engages them. And yes, you consult a statistician, and yes, they do your analysis, so they help with interpretation, but I thought it was cute to highlight that. So what are then some strategies at the bedside for implementing research in clinical practice? Well, first and foremost, it's promoting the use of research. So increasing awareness of research, highlighting how you have done or other colleagues have done and changed clinical practice and why it may be important to replicate into a pilot study to test something out. Provide access to resources so that people know what research entails and what it's involved. And then implement research initiatives, so really taking the time to implement pilot work and clinical projects at the bedside. Obviously, educating staff is an important point so that they realize the benefit of why we're engaging in a research project, because attitudes are so important. And in terms of resources, there's so many online tutorials, websites, you all have access to, obviously, journals through your affiliation at your organizations, but certainly journal clubs is a nice way to approach research in a positive way and to show people, yes, you can read research, yes, you can interpret it, and then see if it can be applied into your clinical practice. And then having a research committee. Many facilities, this is a nice way to have interprofessional research, is by having a team that comes together to look at current projects and projects that could be implemented as well. So a lot of resources. The Society of Critical Care Medicine hosts a journal club webcast featuring pharmacy topics. This was originally started by the pharmacy section, but it's open to all members, and it's held on the third Friday each month. It's a nice way to look at how a journal club is run, so it's a nice example. There's other journal clubs online that can be tapped into, American Thoracic Society and others, so it's a nice way to stay up to date with current literature. Annals of Internal Medicine does a pulmonary and critical care journal club, so looking at recent research as well to keep up to date. And there's also a wiki journal club for critical care, so keeping up to date with clinical trials. So I think the more types of internet-based and web-based resources there are, the better, because I think we don't have time to read our clinical journals. I know when I receive my journals, I sort of selectively go through them, not reading every single article. Don't tell Dr. Buckman that, but certainly we know that it's time-consuming, and clinicians don't have that sort of time. So making it easy. The American Journal of Critical Care also has its evidence-based reviews, where they take a research article. They actually interview the author, and they have a showcase in their journal, interviewing the author related to their research and highlighting applications to clinical practice. They also have a nice resource on their website for critiquing research. So you access it from their website. They go through the steps of a journal club, how to set it up, how to hold it. So for those sites that haven't formally started a journal club, it's a nice resource. And they also highlight on their website guidelines for critiquing research. So it's a nice way to engage clinical staff in terms of looking at the literature and evaluating research for application to practice. So what are some other ways then, aside from just looking at resources and promoting research? Certainly looking at relevant, user-friendly information. So posting relevant articles that relate to your care area and your break rooms, where staff have their lunch area, so that you really have access and exposure to those. We've actually done a few things trying to stimulate staff interest in research, and one of those has been our research briefs and our bathroom reviews. So each month, one of our staff volunteered to look in the critical care literature and write a one-page summary of a research article, and we post those in our bathrooms, but we change them on a monthly basis, because we know that if you don't change posters and signs, it sort of fade into the woodwork. We've also done some postings of research briefs. And one of our ICU nurses, and this is an example of how she actually did her posting, you don't need to necessarily read the words, but she took a research article, and she did a one-page summary of that article, and she posted it in the ICU, and she's been doing this now for quite some time. Well, over time, she found that more staff were starting to take down the research article and read it because they were push-pin holes that were being put into that research article versus her one-page summary. I said, Joyce, I said, you could have a research study. I said, you could count the holes over time to see, you know, you're getting people more comfortable with reading research. And that's really what it's about, is making staff more comfortable with the idea of engaging in research and doing research at the bedside. So identifying, developing, and implementing projects, really that's the key step. You can talk about it, you can engage your clinicians, but now you want to move them into the area of really doing research and obviously publishing it. I mean, that reflects well on the team as well. So targeting established indicators is one strategy. Certainly there's lots of resources that pertain to acute and critical care. The National Quality Forum is just one of those. A number of indicators that pertain to critical illness. We actually targeted urinary tract infections several years ago in our medical ICU because our rates were a bit higher than what we wanted them to be. Now at Rush University Medical Center, we're a 620-bed academic medical center. We have 4 adult ICU, averaging over 8,000 admissions, and in each of the ICUs over 100 clinical staffs, over 400 total. So obviously it's a challenge to make sure that everyone's up to date with initiatives. But our medical ICU took on a project. It was not research per se, it was quality improvement, but they ended up being able to publish this project. And it actually was a nice forum or entryway into research for this clinical team. So Ellen Alpern is a seasoned nurse practitioner who was in the medical ICU for many years. Katie Colleen is the clinical nurse specialist. Alice and Amanda are clinical staff nurses. Gauram Patel is our clinical pharmacist, and Omar Latif at that time was the director of the medical ICU. So every month we meet together as the ICU, 4 ICUs in terms of our acute and critical care quality committees, and we share information on all our quality indicators. So at that time, the medical ICU was having sort of up and down with their urinary tract infections and really wanted to bring it down within appropriate rates. So they implemented a multidisciplinary initiative to focus on decreasing use of catheters in the ICU. And they first did a literature review to showcase appropriate indications so that this was used on rounds for staff to say, does the patient meet the need to have an indwelling catheter, and if not, then it should be removed. And you'll see the 4th line down there, nurses concerned about patients' discomfort. Actually, Ellen found out that some of the clinical staff was resistant to discontinue catheters in some patients because they perceived that the patients would be incontinent, have to have linens changed, would increase nursing workload. And Ellen, being there for many years, was wise, and she said, well, okay, we're going to monitor the circumstances, but let's just do a pilot for several months to see the impact of this clinical change project. So they did that, and during a 6-month period, they reinforced on daily rounds the importance of monitoring patients with catheters and not using them if necessary or discontinuing them. And then they compared it to the 11 months prior. So what they found during their study was that they were able to decrease the number of urinary catheter device days. But what was most striking was this data. During that 6-month interval, they had no catheter-associated urinary tract infections during that study timeline. And so this was most telling. They also found out they did not have increased incidence of incontinence or skin breakdown or increased workload. And so this affirmed to the staff the benefit of what they were doing. This was in our medical ICU, and our ICUs are a bit competitive. I don't know if yours are. And so it actually was adapted in our other ICUs so they can improve their performance. And we now have an institutional-wide policy at our medical center that any nurse can discontinue a catheter without a physician's order as long as the patient meets the criteria for discontinuation. It was approved by the medical staff, so it's almost like a policy. So I showcased this project to highlight that one clinical area can do an improvement initiative that can change practice throughout the entire organization. And this is really the emphasis when I speak on clinical research. How can we improve practice for our patients that really improves care throughout our organizations or even through our systems? This is the nature of clinical practice change, and we often do it normally. We're always doing different types of initiatives, but we're not pausing and putting it into that research framework by collecting baseline and pulse data to really showcase, and then taking it the next steps, publishing and presenting on it. It really showcases the efforts of the team. Other strategies, certainly administrative support is important. We have, for our senior nurses, we have a clinical ladder. So when nurses are at step 3, they actually have to be engaged in order to get to step 4. They have to be engaged in an active research or evidence-based practice project. So we really support that by giving them release time during their work days. They probably get about 4 hours a week that they have release time to data collect or to review charts or get data from the medical record or to help with moving the project along. So that has been beneficial. Obviously, submitting to the Institutional Review Board. Many of our quality improvement projects do not need to be submitted to the IRB, but we find it beneficial to do so because many of the clinical journals are asking for review, proof of review. And our IRB has actually created a separate pathway now that instead of the traditional, full or expedited or exempt, we now have a QI so that they oftentimes get a several-day turnaround on those projects. But it's been so beneficial because you then have assurance when you go to publish if one of those journals requires that you have that in advance. And so that's been helpful as well. Having champions, we definitely have unit-based champions that are responsible for the projects, and that helps to ensure that work is being done and progress is being made, and they report back on that, and that's been helpful as well. And then targeting indicators that are helpful to practice or important to clinical practice. That helps to bring relevance to research. This was actually published just last month, and I thought it was a very innovative example of clinical research. It was a project that was looking at patients' hand hygiene, and you can relate that we're all focused as clinicians to do proper hand hygiene, and possibly we engage families when they come into the unit to do hand hygiene, but how much have we engaged patients? And so I thought this was a novel way. They actually had patients do hand hygiene. Each of them had hand hygiene containers, and they were focused on not only improving hand hygiene, but looking at the impact of that on their hospital-acquired infections. So they promoted use of either hand washing or hand sanitizer. They gave education to patients and families. And over a several-month period, they really reinforced this. They had patients actually complete a survey during this intervention as well as afterwards, and they track their infection data. And they showcase that patients before the intervention actually improved in terms of those patients who were offered hand hygiene by the staff. So staff were very attuned to having patients do hand hygiene at the bedside. They also reported that patients were encouraged to carry out hand hygiene before the bathroom use or after bathroom use or before meals. So staff was reinforcing to patients when they should do hand hygiene in the unit. And they showcased that throughout their project, they were able to implement hand hygiene interventions that rates of infections, both vancomycin-resistant enterococcus and methicillin-resistant Staph aureus, those infections were decreased over time, and this project actually increased hand hygiene compliance by patients in their unit. So I thought it was sort of a novel way to showcase, yes, we're always focusing on clinicians, but engaging patients in the process can also be beneficial over time as well. And they certainly were able to get a nice publication on the results of this bedside project. But we all know that there's challenges to overcoming in order to make sure that clinical research, especially in critical care areas, are successful. So Linda Klein and her colleagues actually highlighted some of the strategies, looking at research not as a roadblock for clinical care, but showcasing to clinicians the benefit of having research in practice. Carefully selecting an initial unit or a champion. I shared with you for our urinary tract infection, we piloted on one unit, and then based on their successes, rolling it out to other units as well. Highlighting positive comments from staff as well as patients can be beneficial to showcase the impact of research. And looking at recruitment strategies to tailor the unit's culture. So what will work in one unit may not work in another. Making sure that there's awareness to overcome challenges to research, particularly for recruitment or implementation. Making sure that there's a regular presence of research on the team, on the unit. And carefully selecting champions. So they highlight a number of strategies that can be used in clinical practice, as well as updating clinical staff on progress on a regular basis. So how can we then ensure that research is integrated into practice? Well, certainly looking at, are the results going to benefit patient care, which we can assuredly showcase in clinical research, And then we can change practice based on some of the pilot work that we do. We may need to change further aspects of that pilot study as we move forward, especially if we're rolling it out to other units. And we may need to evaluate how to further change it. So one area that we've been focusing in at our medical center has been the use of pet therapy. And this has been utilized for patients and for families. But we actually observed, we have Toby, who's an animal therapy dog that comes to our ICUs every Monday. And one of the observations that we had of our clinical staff is that when Toby came into the unit, staff would stop and pause and say, oh, Toby's here. And so the mood sort of changed in the ICU. Everyone sort of paused for a moment. The dog was there. So it was sort of an unintended consequence that the staff was actually getting benefit from pet therapy. So we moved forward to really study this in a formal clinical project as well. So I just wanted to showcase, share with you this short video. One of the local news channels highlighted this initiative on one of the evening news. Oh, sorry. We did test it. We tested it before, Marina. I know we did. Marina, you also had it. I think we had it. She also had it minimized. Yeah, I want to show this to you. So I think it's this one.
Okay, if we right-click it. Yeah, right-click where that window is.
One of the big hospitals in Chicago can be stressful.
But we're looking at other times where I do it next to family or the patient, and it could be frustrating.
Do you have the statistical results of the study?
Yeah. Despite
Even nurse, one of the big hospitals in Chicago can be stressful.
but we're looking at other times where I do it next to family or the patient, and it could be frustrating as well for us.
To help the staff, Western University Medical Center started a monthly program for nurses, doctors, students, and other staffers where they spend time relaxing with dogs.
My stress level was decreased. I felt very wonderfully heavy.
Pet therapy for patients has grown in popularity. The hospital is studying if the animals have potential effects on those providing care.
So we're really hoping that that's going to help the stress and burnout that people feel on a day-to-day basis, and that they can spend a few minutes down here, feel a little refreshed, and go back to the unit and take care of patients.
Before interacting with the patients, the workers get their blood pressure checked and rate their stress levels. The tests are then repeated after the timely encounter.
I could feel the big sighs coming out of me when I was with the dog, so I know that just coming to this has made my day less stressful.
Today's happy companions are many collaborative mix. A shepherd mix named Rocco and Dallas Augustine. Those providing the dogs, they look to reinforce the benefits of medical arts, who might recommend it to others.
Hospital staff is not a population that we typically have an opportunity to provide these services to, and we're always looking for opportunities to get therapy out in front of more people.
Early indications are that formulated healers are proving to be very beneficial for these healers. Carrying mental finger associated effects. Being a nurse at one of the biggest hospitals in Chicago can be stressful.
So that just highlights, you know, how something that evolved from regular patient care ended up being beneficial for our clinical staff, and was a nice way to showcase how you can integrate research into clinical practice to demonstrate the benefit of something that's as simple just as pet therapy. Our institution has become a lot more focused, I think, on having such type of relief measures for clinical staff. We now have roving massage days where we have massage therapists go to the units and provide a 10-minute massage, and they do the same thing, the pre and post assessment of stress levels. We also have respite rooms on our clinical floors that we're encouraging staff to utilize, and looking at having on-site. We have a meditation room. So we have mindfulness meditation classes that are given to staff, trying to really improve the work-life balance and have a healthy work environment. So I think that's another area of focus, and we're doing research related to those initiatives as well. So it's a nice way to show staff in a different format the benefits of research, because I think research has a certain perspective on some clinicians that it's only about, alternating new types of drugs or randomizing patients to receive a therapy or not. And, there's all types of clinical research, including those that benefit clinical staff as well. So some additional strategies, obviously building support is important. Communication is essential. When you roll anything out, you have to make sure that the right people know that it's being done. We encourage staff participation at all stages so that they're aware and they're actively engaged. Here's a cartoon that says, what I'm suggesting is a research partnership. I'll think up the right ideas and you'll do the research. Certainly we have researchers on site, but we need to engage the clinical staff. It can't be a researcher's idea that the clinical staff need to carry out. The clinical staff really benefit by being involved in the process, including planning, implementation, and evaluation as well. And of course, what's a realistic research team? You see many people engaged around the table, even a dog. Sometimes when we have an idea for a project, everyone wants to be involved, but really to be meaningful, you need a core work group that needs to carry out some of these projects. So we try and assign different roles for people if they're not actively involved with the carrying out of the initiative, that they're helping to disseminate or they're helping with other ways. So making sure there's a role for everyone, especially those who want to be involved. Showcasing strategies, certainly such things as clinical grand rounds, formal programs have helped. Institutional newsletters, poster presentations. We have a research forum every year where we have every unit showcase their projects. People come with posters. It's a nice way to be able to identify people's efforts through our research forum day as well. And some of our clinical staff have had their first experience at presenting these clinical projects at some of the national meetings and conferences. And it's just a nice opportunity for people who have never done this before. We have a day where we practice with them if they're going to do a poster presentation or an oral presentation so they can be prepared, but it's a nice way, again, to showcase the institution. Seeking funding for pilot studies, lots of small grants available that are helpful for some of our national organizations. This is a way to sort of jumpstart some of these projects. As I indicated, we link participation to our clinical ladder for the nurses, and that has helped. And we provide resources for them to publish and present on their projects as well. So oftentimes people will say, oh, well, I don't know anything about research. Well, certainly finding mentorship and linking people up are helpful for that. And then to provide resources for research in the clinical setting, really essential pieces. And lack of time, we need to negotiate time for clinicians to have some non-patient care time to be engaged in research as well. So here's a mouse. He's going to get his cheese and he has a helmet on. So we always highlight for research, be prepared for anything, right? You have to have a backup if the data doesn't get collected or the computer goes down or such and such. So, we know that data may be missing, and so you just do your best as you go forward with initiatives as well. So building support, it's essential. We have our reference librarian that comes to our clinical research meetings to be able to assist staff with support as well. Research consultants, that's important, helping staff to apply for some of the clinical grants, really making sure they'll be successful. And then having relationships. We've had an academic clinical partnership at our institution for several years. So we have our Center for Clinical Research and Scholarship that we started in 2007, which is a formal link between the university and the medical center. It has originally developed to help our Magnet Designation. When you have Magnet Designation, there's an expectation that you have an increase in clinical research initiative projects. It was actually started from our Nursing Alumni Association, but it's not a center solely for nursing research, it's for clinical research. So we have pharmacists who get some of our grants, physicians. The teams have to be multi-professional. We give out pilot grants up to 10 a year. About 5,000 each. So there's incentives for people to propose clinical projects that will be done in the institution, and we also pair up our residents, our fellows to get research experience, as well as our students at the university. So we provide mentorship to our teams. This is showcasing one of our teams in the medical ICU. That's actually Ellen, Alpern, and Katie with Dr. Gurga. And one of our clinical staff nurses, Amanda. So we pair up people who want to have experience with research, and it's a nice way to at least enlist them in engaging research initiatives as well. So we support them through the IRB process. We help them with some of the abstract and poster development. as well as ensure that the team is prepared to put forth their manuscript for publication. We do sponsor clinical grand rounds, and we've had a number of people, including international people, come through and speak on their research. People always enjoy this, and just like as you're having for your chapter, it's always helpful to have a speaker come and engage people and give them ideas as well. We have collaborated with our evidence-based practice research committee to co-host a research forum every year, which is a nice way for people to present on their projects or their project ideas and to get feedback. And one of the projects that we've done throughout the years, I like to highlight this, is we call it our Journey Project. Most of us belong to professional organizations, and you get a journal that is usually mailed to your home or to your office, and many times, and I was guilty of doing this myself, I would keep the journals in my office thinking, well, someday I'll need to look at that. But the reality is, now that we can get everything through the library, PDF, open access, we don't need our hard copy journals. So for the past 5 years, we've done a recycling program where we have clinicians bring in the journal either the same month they get it, when they're done with it, or the next month, and we recycle them to the clinical units. So now at each of our break rooms in our units, we have clinical journals. It used to be that people were up to date with, Angeline and Jolie and Brad Pitt, because they would get those throwaway journals. You'd see them in the break rooms, but now we have actually our research journals, critical care medicine, chest, whatever, so that others can benefit from having access to those resources, the clinical guidelines. It really has been beneficial, and reality is people don't miss not having their journals in their, on their shelves. So it's been a nice way to promote access to research and evidence-based practice. So in summary, I just wanted to share a few ways that we have found beneficial to highlight evidence-based practice and research in the ICU, to highlight the importance of research, to engage our frontline clinicians, which is an important part. As senior clinicians, some of you have your own research grants and you're doing your research in your areas, and that's wonderful. But I think as teams, we need to look at team-based initiatives that can benefit patient care frontline, and so that's beneficial as well. So looking at strategies to really facilitate the use of bedside clinical research has definitely promoted better practices for patient care as well. So my son, who is now age 20, actually drew this for me when he was age 6. I was working one summer to get a research grant in and trying to meet deadlines and away from home for long hours. And so I came home and he wrote this for me. It says, "Dear Mom, I know that doing research is hard work. I know. Why don't you take a break and go do something fun? Love, Horace." So research is hard work, and you need to take a break. Obviously, we're so focused, some of us that are into a lot of research, that we get enthralled with it, but we do need to have a balance with it as well. But I share this because it has, I've taken it with me all these years, and it's just a nice way to showcase balance as well. So with that, I wanted to thank you for the opportunity to be able to just talk briefly. I know we've all had a long day, but I hope that we can have a little bit of time for discussion and dialogue. I think particularly while I'm here face-to-face with some of you, as well as having those of you who are participating at the distance sites to maybe highlight some of the things that you're doing in your care areas, I would find that most beneficial as well. So I think I'll open it up for questions and dialogue, and I think at the most, I'd like to go home saying what some of the Southeast chapter sites are doing to promote best practices through clinical research at their sites as well. So thank you so much. Yes, Dr. Martin.
I really appreciate that, because it's often a lot of the things that we don't think about that are so intuitive. We could be doing this true research, and your point that calling it research often makes it more intimidating. But
Right.
I like some of the simple examples of using the journals and recycling them to make things feel less intimidating.
Sure.
But I also think that critical care is really the right environment to be doing this, because we already are focused on multi-professional care.
Mm-hmm.
So to really get the entire care spectrum of team members together to do research makes a lot of sense too. And it's something we probably, I'm sure, as a team can do even better than we do now.
Right. Yes, I was sharing when I met with some colleagues at lunch today at the hospital. We have had a number of initiatives led by a variety of individuals at our care center, and most recently, one of our pharmacists led the participation of our institution in the ABC DEF Collaborative, and it was amazing through the course of a year how he was able to engage champions in each of the ICUs. They changed the protocols for sedation and analgesia. We changed the timing of our SATs, SBTs. We improved our documentation of delirium screening. We improved the ambulation of patients, and giving that data month to month back to the clinical staff to showcase you are making great improvements in what you're doing was really quite reinforcing. So it really helped to engage people. And now they're at the stage where they have their data, they're getting ready to publish it and showcase. They were able to showcase a decreased time on the ventilator because of timing of SBTs, SATs, and decreasing sedation as well as ambulation. So, and we know these are best practices. We read about it in our journals, but I think bringing it to the bedside and showing the teams how we can improve by giving multi-professional care and doing a multi-professional research at the same time. So we've definitely seen it. And a couple of people shared today some of the projects that you're doing very greatly in terms of your sepsis recognition initiatives. And I thought that was a good example of how you're engaging even the EMTs, to have early recognition and putting forth new initiatives. So that was another nice example. So I don't know how your site's tapping, but can you get them to?
Absolutely.
Great. Sure. We can go line by line, right? I find it hard to leverage clinical staff to assist research endeavors in community hospitals. Any thoughts on the difference in doing research between community and academic hospitals? Good question. And we have a partner hospital, Russell Park Hospital, that is a community hospital. And so we engage them in clinical project work as well. And it works the same way. So I think there's a perception that academic medical centers have all these resources and are really more focused on research. And that really is not the case. I mean, at the community hospital, sometimes they have less barriers because they're smaller, they have more cohesion, they know who to go to in terms of key stakeholders, whereas academic medical centers, you might have to go through a number of hoops to try and gain support and implement. So it's not that community hospitals are in a different position. I think they sometimes have, they can have easier way to implement clinical research, and so it should not be a barrier not being an academic medical center. Now, one of the things we had to support them with, they did not have a statistician, so we had to give them statistical support as well. But the same thing goes for them. They had reference librarian support, they had a research team, they did clinical journal club. So they started out with different initiatives over time and then built that into doing clinical projects.
Enjoyed your talk. My question is, from the standpoint of a lot of the early pilot studies and the size and number, when you go full scale, should you publish some of the pilot studies as introductory to the concept?
Yes.
Success that it is here?
Yes, good question. The question was asked about pilot studies. Is it beneficial to publish and disseminate some of those as an initial first step? Yes, definitely, because there are so many settings that will benefit from even pilot work. And you get ideas from pilot work. If you see an abstract on something that's innovative, you may want to contact the author to see how they did the study, even if it's an abstract that's published versus an entire journal article. But certainly it's reinforcing to the staff to have their work published. There are so many clinical journals. I think when we think about publishing, we think about the high impact journals. It can be in the top 5 or 10 in their areas. But there are so many more that are really looking for clinical exemplars, that they are not looking for rigorous research designed initiatives. They're looking for clinical application of research or quality improvement. They have special journal columns for that in some of the clinical journals. So really being persistent. I think there's been some resistance to publish, particularly if a team has gotten rejected. And you have to remember that getting rejected is not a personal rejection. There's some journals that have a lot of submissions and their acceptance rate, just happen to be low. So you need to have at least 5 or 6 journals on your list that once you submit it, it doesn't get accepted at one. It's a process. You be persistent. You just go to your next one. You know, it used to be in the world of publishing, you would traditionally send what was called a query letter, where you would send a formal letter to a journal to ask of their interest. Well, nowadays, with the internet, you simply go to the website of a journal, there's a corresponding editor, and you email them to assess their interest in reviewing your manuscript for publication. That's a nice way to send feelers out, because you can send a query email to 5, 6, 7, 8 journals at the same time to see what response you get, whereas when you submit a manuscript, you only submit it to one journal at a time. You'd be surprised. There's been a variety of responses from some of our experiences. We had one clinical team that sent the query out to 5 different journals, and they got the typical response back from 3 of them that said, "Thank you for interest in our journal. You know, here's the author instructions website. And we look forward to seeing your manuscript." Well, one response actually came from a clinical journal that said, "We're having a special supplement in November of this year on this exact topic. We would like to consider your clinical project for a fit with our supplement." So it was a nice way for the team to feel out the different journals and to see who was most interested. And it turned out that they submitted to that journal. They had to do revision work. It didn't get accepted right away, but they revised it several times and it got published in that supplement. So, you know, it was a nice experience for that team. So yes, you certainly should look to publish even pilot studies, because they all have stories that are behind them, lessons learned. You know, you always identify when you write it out, what would you suggest, you know, as different areas of focus. So it's always beneficial. Okay. Advice on utilizing, oh, good one, hospital IT department to extract data. Do they need research education or just a list of data points you need? Good question. You know, one of the things we have found out, we probably did it the hard way. We have Epic, and we would do a clinical project, but not quite know how we were going to get the data out of Epic until after we had started down the road of doing the initiative. Well, we got smart, and we now have a clinical IT person on our project teams before we even start on a clinical project. So they know how to abstract the information that we need downstream. They're also able to do special builds in Epic to be able to have reports, coding reports and such, to get our data points out for us. So it really is a strategy, and I know some places are migrating to Epic, and that's a nice way, is to have them on board right away. And they're data persons, so you know, they don't need to have rigorous research training. They may need to take a city course, you know, IRB training if they're exposed to HIPAA-related data that they're pulling. But no, they don't need to have rigorous research experience. They're really the support for us to give us the data we need. So, yes?
So I'm curious about, if you could elaborate on what you were talking about earlier with taking a pause to collect baseline data before you start into your clinical project, and whether you ever experience pushback from clinical staff when it is their best practice that what you're trying to improve upon needs to be done, but taking that pause could potentially negatively impact those who are in the baseline group, those patients. And the reason I ask that is because with our EMS initiative, we got a lot of that feedback. You know, paramedics and EMTs really wanted to improve their ability to identify sepsis in the field, but because it was oriented around a research project, you know, we needed to have that baseline data. We didn't have the reporting infrastructure in place to begin with, and so it's something we had to develop up front. And I'm just curious if you've experienced that and how you handled it.
Yeah, that's an important point. And obviously, you know, if there's a therapy or a treatment that's going to improve patient care, it needs to be given regardless of whether a research study is planned or not. You know, that's first and foremost. And if it occurs while you're doing your project, those are just outliers. You know, they're not included in your project data, which is fine. You know, it's hard to do a clinical research project in live time in a clinical setting. It's not pure, like if you had a, you know, if you were in a lab setting or such. So I think we have to be flexible so that we know that it's not going to normally be enroll all comers. It may be that some people are getting the therapy in advance of us putting together our protocol, and so those are just not patients that we include. Those are just patients who get treated. So I I think we have to be flexible in that respect, yes. Now, how did it work out in your case with the EMTs for the sepsis project?
We needed time to plan and educate around the new initiative anyway, so we ended up using that time that it took to create our infrastructure to deploy the initiative to collect our baseline data.
Yeah, and sometimes, you know, with the way we have our electronic medical record, you can collect retrospective baseline data even if you move forward. You know, if you have certain the dates that you're implementing what's new, versus having clean collection of your baseline data before you proceed down that path of the intervention. So it's just sort of figuring out what works for your system. Great. Yes?
One other question, maybe a little bit what Dr. Leo was asking, but what's your thought on, and I had to review it, I had mixed emotions about it, but publishing of conceptual models. And there wasn't a lot of data to support it, but conceptually, without inviting a group of somebody else to do it, and I was like, we should take it another step and conduct it, but nevertheless, they should use without somebody to take it, go implement it, and then test and get results. So either way, it's potentially beneficial that else we're so used to people actually doing it and then publishing. So what's your thought on?
Yeah, I guess it depends on the circumstances and it depends on the people that are involved with the project. You know, if they find that they have a useful model that they want to publish as a solo article, there's nothing that precludes that. You know, they may benefit from it by having others take that model and test it in certain ways or implement it in certain clinical projects versus waiting to publish it with the results of a project as well. So, you know, I think that's certainly something that's optional that can be done. And if there's a journal that wants to publish something, I think people would say they'd rather have 2 publications versus 1. So, you know, it really depends, but certainly that's an option as well. Well, thank you so much. I enjoyed the opportunity to network and dialogue and engage with you here, and hopefully the individuals that are online with us have benefited as well. Again, I have to thank the chapter for all of their hard work with really engaging the 7 states that are involved in the chapter. I think that's quite a feat, and you're to be congratulated for all the ongoing initiatives that you're improving care and really bringing together the clinicians to help support the Society of Critical Care Medicine. So